Hi, my name is Shahady. We're here at the Cardiometabolic Risk Summit in Las Vegas, and I'm here with Margo Minissian. Margo is a nurse practitioner and a clinical nurse scientist at Cedars-Sinai Heart Institute. We're really pleased to have you here.
Thank you for having me.
Yeah, now just attended the nice interaction where there were 4 of you on stage. A patient was presented. And I really was fascinated by it. It really was comprehensive what we went through. Well, I'd like to focus on the part, because you're a lipid specialist, and talk about if we were treating a patient with a statin, which statin would you use?
Well, I think that for individuals who qualify for a statin based on an ASCVD risk score, generally we will go with a moderate, low to moderate intensity statin depending on their risk. If they're a secondary prevention patient, that would be somebody who would require high intensity statins. And believe it or not, there's actually only 2 medications that qualify as high intensity. All the other statins are considered low.
And what are they? What are the 2?
That's rosuvastatin 20 or 40 milligrams, or atorvastatin 40 or 80 milligrams. Those are high intensity statins.
Okay, and this patient would be primary prevention? Did you have today?
Today was for primary prevention. So what was so exciting about her and what led to a lot of discussion was the fact that her ASCVD risk score was 5.2. And that is considered a 2B recommendation to discuss and possibly start statin therapy. And that would be a low or moderate dose if, after having a provider-patient discussion, that was the decision to move forward.
Okay, primary, secondary, just what would be something I know in the history that would tell me it's secondary prevention?
Absolutely. So an individual who qualifies for secondary prevention is someone who has had revascularization of their coronary arteries, somebody who has had a stroke that has been due to atherogenic causes, somebody with peripheral vascular disease, an individual who has obstructive heart disease. These are all people who are considered secondary prevention. I think it's also fair to put in there somebody who's had a heart attack, such as a non-STEMI, non-ST elevation MI, or an ST elevation MI. Oftentimes, the magic pills include a statin.
So a significant cardiovascular event,
Correct.
or if the risk is higher, what number do you go for? So you said it's 5%. What number would say, I definitely would say this is, I would treat it? What percentage?
So the new guidelines that came out in 2013 through the American College of Cardiology and the American Heart Association discuss reduced reduction of risk. So if her 10-year atherosclerotic cardiovascular risk, which is what ASCVD stands for, if her risk is 5% and she wanted to move forward after the discussion to move with a statin, then we actually treat by statin dosing. We actually don't treat to LDL targets anymore, which is a newer idea for many of us.
I'm going to disagree with you on that. The National Lipid Association does have targets. So how do you, obviously you go with the ACC, the AHA guidelines. So how do you justify? I'm sure some of your colleagues still use targets.
Well, I agree with you because I also am part of the National Lipid Foundation. I'm a member of them as well. And it really depends on the patient. You have to look at the patient. So we're talking about a well primary prevention patient. The ACC-AHA guidelines are perfect for this individual. She fits right into the randomized clinical control trial. That's where you would prescribe based on dosing. Now, there are individuals that we do look at LDL reduction. In the spring of 2016, we came out with an expert consensus model on utilizing non-statin therapies. And in there, I was one of those co-authors, and we discussed using LDL and percentages based on these people who have familial hyperlipidemia primarily, or those secondary prevention patients. Those are the patients that you've put them on the highest tolerated dose of statin, and you and the patient are still not satisfied with the results that they've gotten. That's when we start to look at those LDL targets.
And you have to make the diagnosis, so you need an LDL. you start the medication, you want to see the effect.
Correct.
Just make sure they're not, for some reason, intolerant.
Correct.
So, and then, okay, so maybe that should be one initially, you get another one, say, what, 1 month, 2 months?
So the guidelines will suggest that after you have either initiated statin therapy or you've adjusted the dose,
Right.
that in our practice, we generally look 4 to 6 weeks after we've made one of those adjustments. The national guidelines will tell you that it's prudent to look at 6 or 12 month periods of time. This is not really to look at the LDL except for looking for compliance.
Right.
That's the primary purpose of checking that LDL.
Right.
And why we do care about that number, because it tells us if the patient's actually taking their medication.
Yeah. Okay. Well, what about the improvement study, which said if you lower it to this number, you do decrease events, which would seem to say, I want to use an LDL low.
Yes, the improvement trial was the very first trial that really was able to show hard outcomes for a statin in addition to ezetimibe. And so in that trial, it's always important to look at the study to see if your patient fits in the study. Today we were discussing a 51-year-old female who was asymptomatic. The improvement trial, 70% of those in the trial were men. They were over the age of 65 predominantly, and they also had acute coronary syndromes. And it took 7 years, but they did then see some good hard outcome results. So I think that it's a good lesson learned that there's a place for all of our patients within all these studies that we do, but we have to be cognizant of the study and really what the demographic of the individuals look like within those studies.
Those are very helpful points, Margo. Thank you very much for being with us.